Welcome to the Wednesday, April 27th Littleton Board of Health meeting. We are meeting virtually again. If anybody has any questions or comments regarding any item, please raise their hand, state their name. You'll have 2 minutes. And it looks like we're going to start. We have a public hearing tonight regarding 20 Paula Beth Road with Doucette Engineering for a variance request. And I'm not sure if Ted is on yet. If he's not, maybe we can jump in and talk to Jim.
Yeah, he's not on yet, so.
Jim, sorry to put you on the spot, but do you mind starting?
Not at all. I was just kind of putting the finishing touches on things, so that works out well. I assume you're referring to the COVID report?
COVID update, yeah.
Sure. So start with the weekly numbers. What I've kind of done is broken it down into the numbers that we see, and they're always a week behind, obviously, total numbers, and then the 2-week rolling. So the past 3 weeks of weekly numbers on the week, starting the 3rd, so they were starting a Saturday and go to Friday. The week of the 3rd, it was 16 cases, the 10th was 13 cases, and the 17th, which is the most current, is 16 cases. The 2-week rolling that we get from the state, and again, it's based on the estimate that I pulled this morning. Today's number was 30. Last week, or the last rolling number last week's was 18, 28, and 32 were the 2 previous weeks. So we did have that drop there last week, but it seems to be back up again for this week. We'll see what the state's numbers are. Every once in a while, my numbers are 1 or 2, one way or the other, even though we're getting the data from the same place. To me, one of those significant numbers I always take a look at is the number of active cases in the state. Last week when we were chatting, it was about 32,000 and some change. Now it's 27,000. So again, that number is going down, which is very good to see. Vaccine numbers, Town of Littleton, this is again a report, I think, as of April 20th, the charts. 57% of the town had received a first dose. 32% of the town had received or are considered fully vaccinated. And each age group that they report, the percentages of fully vaccinated have increased. So it's good to see that those numbers are still kind of going forward. Probably the biggest thing that happened COVID-wise today was the governor's announcement, the press conference. And it'll be interesting to see if they let boards of health know ahead of time again, because one of the towns decided to go put the announcement that we're receiving just before the governor's announcement up on their Facebook page. And while we were still in the Department of Public Health meeting, the Department of Public Health asked them to actually take the information down because the governor hadn't quite announced it yet. So we'll see if that one bad action by somebody is going to keep us from getting the information just ahead of time. But they have a series of not deadlines, but timelines at which they're going to relax openings based on the public health data. And the first one that it comes is Friday. And they're going to modify the order. And again, the order's not up yet. Hopefully it will be there either Thursday night or Friday. Rolling back the mask mandate for outdoors. If you can stay socially distant, if you can stay more than 6 feet outdoors, they'll drop the requirement for wearing masks outside. All of these changes in the orders, the reason why it's important to actually wait for the actual order to come out is that in that order, they'll list the exemptions. Like currently in the current mask order, it talks about when you have to wear a mask, but there's a section in there that talks about exceptions. And that's really important when you're looking at, right now, everyone's pretty happy that outdoor, they'll relax it, but I want to see the actual specifics in the order to see, because one of the things we're told is even with the governor's order today, if you're subject to a sector-specific workplace safety standard, you follow the requirements for those mask wearing requirements. That's within that sector-specific. The same thing will happen, I'm sure, when they modify the order for Friday. So it'll be important to see what those exceptions are. And so good to hear that that's being reduced or rolled back, but we need to wait for the details. And then they went into a series of timelines for entering phase 4, step 2. And the timelines are May 10th, May 29th, and then August 1st. So, and again, in the governor's press conference, he goes through the what'll open or what'll be changed and modified for those timelines. The May 10th timeline, large venues, they'll be able to increase their capacity. Amusement parks will be in, theme parks and water parks will be able to open at a certain 50% capacity. Road races and outdoor organized amateur and professional group athletic events, it's a lot of words, will be allowed, but they need to submit a COVID safety plan to the Board of Health. If they're multi-town, so think Boston Marathon, they would have to actually submit that COVID safety plan to the state. But any local road race, they would need to be able to, they need to send that COVID report to the board for a review. They're going to make some changes. And again, this is one I'm not sure what all those changes are going to be. I'll have to wait until the sector specific comes out with regards to youth and athletic sports. The Executive Office for Environmental Affairs has a pretty lengthy document that describes how youth and amateur adult sports are played. So they're going to make some modifications to that standard. And then singing will be permitted indoors under certain circumstances. Again, it'll be important to see what those specific requirements are to allow that to happen. So again, those are the rollbacks for the 10th. For the 29th, and again, these all state that subject to public health and vaccination data, gathering limits will be increased to 200 people indoors and 250 people outdoors. For event venues, public settings, and private settings. Again, it'll be interesting to see what the specifics are because that's a pretty big jump from what they are, particularly for the private settings. It's a little bit bigger for the current indoor-outdoor in public settings, but it's a big jump for the private settings. Certain industries, so street festivals and parades and agricultural events, again, subject to public health and vaccine data, could operate at 50% capacity. During a public health call, they were asked, how do you determine what 50% of your parade crowd was? There wasn't a real good answer. So it's going to be a judgment call in that regard. Probably one that'll make people happy: bars, beer gardens, breweries, wineries, distilleries can open, but they're subject to the restaurant rules, which means you can't stand at the bar, but you can sit at a table and be served alcohol without having to buy food. So again, and again, I've had a number of conversations with people this week, and particularly around the school requirements or the DESI requirements for the schools, but the 3-foot offset. I think it's important, as the public sees numbers getting better and more people getting vaccinated, that the governor reflect that in what is and isn't allowed to open. Whether we all agree it's a good thing or a bad thing, I think in people's mind that if you're saying things are getting better, then what they should be able to do should reflect that, whether that's just a human nature thing or not. So I think part of that is this here. And again, they talk about subject to public health and vaccination data. The next big push is August 1st, and it sounds like they'll roll back just about everything else that they hadn't rolled back in phase 4, step 2, as long as things are going along well. So those are the changes. I don't know if we lay all that out. The governor's thinking to lay all this out so that people will behave and do the right thing and wear masks where they have to, just so that the numbers continue to go down so that this plan can actually take place. That is my hope, because I always tell people when they say they're sick of the pandemic, I say nobody's more sick of this pandemic than the public health department. So, so that's the report I have for this evening.
All right. Can you stick around because I guess Ted is here?
Yep.
Yeah. And so, Judy, if you can let Ted in, thanks.
I've got him coming in.
Oh, thanks, Judy. All right, Janet.
So Ted, you can unmute yourself and share your screen, please.
Yep. All right. I had this as 7. Was I late?
Yeah. We were ready at 7.
What time did I get here?
I don't know.
5 or 7.
Hold on. I was
7:01. You're fine.
I had the plan up, and then I think as Jim was talking, I fell asleep and my head hit the keyboard, so I got to bring my plan back up.
No way. Jim's information is always entertaining.
I'll try.
I
not
don't,
to
it
be
has nothing to
offended.
do with Jim. It has to do with the information, I think.
You're wearing a different outfit tonight, too.
Yeah, it actually looks like a t-shirt, so I shouldn't wear it, but it's just it's a sweater. I don't have my logo gear on. Is that what it is?
Yeah, I mean, that's just, it's unnerving.
No, last time I had something on that you liked.
Yes, it is. It was.
You thought I had a Chelsea shirt or something, yeah.
Yeah, it was.
All right. Let's see. All right. Good evening, Ted Doucette for the record. So this is a property on Paula Beth. It's up near Loxley. This is 20, this is 22 Paula Beth, 24 is in this area, and then Loxley is right down this way here. So this is a failed septic system. It's a difficult site. It's high groundwater and poor soil. So we have to have a raised system. And because of the regulation, the variance that we're asking for is the use of a barrier, which I don't know if you guys read that variance, but we've talked about this before. I think it's poorly worded where, it's supposed to be when a barrier is within 10 feet of a property line, but it's the way it's worded now. We need to do it anytime there's a barrier. So there is the house here, obviously Paula Beth Street here, house, there's a septic tank here, and there's some sort of sewage disposal system. I believe it's actually in this area here off the driveway. This is a paved driveway here. Not much options here. So we're going to go into a septic tank, a pump chamber, and then we're going to pump up to a leach field here, which is a Presby system. Again, everyone knows it helps us get a little bit closer to the groundwater, and it reduces the size of the system and provides, the state has determined that it provides additional treatment. So we're asking for an offset from reduction of groundwater, which is part of the Presby approval is if the Board of Health formally approves it. And then also asking to allow the inlet and outlets of the septic tank and pump chamber to be less than 12 inches above groundwater. Like I said, the groundwater is really high out there. And what we're going to do to help that is we're going to just pour some concrete right around the inlet and outlet here. It won't look that square, but they'll just mix up a bag of concrete, put it on there, making sure it packs in, and hopefully seal those there. We are using monolithic tank and pump chamber, and then pumping up across the lot line to the leach field here. Also that we have to use, we could not, when we went out here, we went to perk it, and the groundwater was too high. So now we have to ask for we're going to use the alternative percolation testing guidance. And that's about it.
Is this on 2 lots, Ted? Do they own 2 lots? Or is that just...
So that was what Jim asked. I don't know what the legal description is. They are defined as 2 lots. This could have been sold off on this, but they're both, I guess they're under common ownership because they have the same person on both deeds. So I don't know what has to be done for those. I don't know if Jim had thoughts on that.
Does anybody have any questions for Ted before we ask Jim his thoughts? Go ahead, Kevin.
Just really quickly, the letter you had sent in for the variance request stated it was a 2-bedroom, but on your plan it says a 4-bedroom. So I just wanted to get a clarification on that.
Oh, yeah. So it is 4-bedroom. That's, just my bad. I think I was given this, to do on, I think it was scheduled on a Wednesday, exactly 2 weeks out. So in my haste, I put in a 2-bedroom letter, but it's 4-bedroom design.
That's public record.
What's that? The 4-bedroom?
Yeah.
Yeah. Let's see. I don't know what I have for that to back that up, but let me see what I have.
Just want to make sure. I'm sure you're right.
Yeah. Property card has 4 bedrooms. And I just lost the screen sharing.
Does that change anything for you, Jim?
It does not.
What was the sieve?
I'm sorry, what's that?
What was your sieve analysis?
It came back as, well, 30-minute per inch. So it'll be standing loam, which, you know, comes out to be the LTAR equal to a 30-minute per inch.
30.
It's probably about the best we would have ever done out there.
Yeah.
Just for full disclosure, there was a time where somebody was interested in buying this lot, and I'm going to go back to screen share here. And I did some additional soil testing. It was more up in this area here, I believe, and then in this area. So you can see how we have this full lot here. I'm trying to keep it away from those areas and keep it down here. So when I did the testing up here, it failed.
Mm.
So I think, you know, Jim said when we were out there, this is probably the best we could have gotten, is to have the actual groundwater interference and be able to get an application rate that's reasonable.
Yeah. Good job.
Louise or Mike, do you guys have any questions? Nope. All right, Jim, can you comment on this?
Sure. So Ted has mentioned the site and that neighborhood, that whole neighborhood's really tough as far as sewage disposal systems. I think the water table out there was at 18 inches. We estimated it at 18 inches. The water was pretty close to those 18 inches, the actual water when we were doing the testing. So again, the reason why we weren't able to run a perk test. Fortunately for the owners, they have that other lot. If you imagine that footprint on their lot, it's not a very pretty site. And that has a barrier just to prevent the fill from covering the driveway. So I don't really have an issue with it. I think it makes for a good repair to that site. It's able to fit on that site and not really impact the home site, if you will. The only question I guess I have for you, Ted, is I didn't see a letter. So did you include the request for the sieve analysis? I didn't see it on the plan, so I wasn't sure. I just want to make sure that gets included in the public record too.
Yeah, it's in the letter.
I just want to make sure.
Alternative. Yeah.
Yeah, it just says alternative to percolation test guidance for systems. It doesn't say anything about specifically sieve.
Yeah,
That's described in that. Yeah.
Okay. Good. I just want to make sure that you have all of those requests so they all get approved. I don't have an issue with it because I think it makes for a very reasonable request and certainly a far better system that's in the ground right now.
Okay. I know we have an
Jim, you
abutter. Sorry, Ted.
Oh, go ahead.
I know we have an abutter, Dave Stolfi. Do you have any questions or comments, Dave?
No, I have no objections to this. Looks reasonable.
Great. Anybody else? Any other abutters? All right. You guys have a motion to approve the variances?
Make a motion to approve as presented.
I'll second.
Can we just sit, I don't know if it makes a difference, but our letter says 2-bedroom. Can we make it contingent on, I don't know if we even need to bring that up.
I can certainly,
Motion to approve 4-bedroom
Okay.
system.
Yeah, okay. And Mike, you seconded, so Kevin, we'll do roll call.
Kevin Baker, yes.
Okay. Louise Nichols,
Louise Nichols, yes.
Mike Zeldin,
Mike Selden, yes.
and Lisa Flanagan, yes. All right. All set, Ted.
That's it?
That was it.
I gotta go back to work now? Okay. All right, thank you all. Have a good
All
night.
right. You too.
Hi, Ted.
All right, so we'll go back to COVID update. Does anybody have any questions for Jim?
I have one or
Go ahead.
two.
Sure, Mike.
I need some tutorials here. My first question, Jim, is, and I hope this one is, how many of the new or the proposed, you don't have to go into detail, of the Baker administration's rollbacks and changes, how close do they comport with the CDC's, shall we say, recommendations, et cetera?
That I don't know because I haven't seen the specifics for what Baker's going to do, and I haven't had a chance to take a look at the CDC site.
Okay.
Often when people are asking, I don't know, I mean, and it may be that the general public kind of interchanges CDC and DPH. As a regulator, I always look at, well, what does DPH say? Because that's what I'm enforcing. And so forgive me for not knowing all the CDC stuff because I concentrate on the DPH.
I'm not asking as a quiz session. It has to do with the fact that that for the first time, I have to admit, although it's not really hard science, I guess it's just my advancing age, I found the CDC diagrams and colors and people and models. It was a nightmare. I tried to diagram it and I decided just to do quantum physics instead. So if they're anything like the CDC things that say you can do this except if it's raining sideways on an alternate Friday when the sun is in the equinox or whatever they have in there, I hope we find a way for our townspeople to make it, whatever comes out, very clearer and not to use yellow and red more than once. So that's the only reason I asked, because I thought you probably are more aware than any of us here about how it is easy to confuse with these kinds of changes.
So what I'm waiting for is for a Friday to see the actual order to know what the exceptions are and how that'll be applied. And then in each time a phase changes or a step in the phase change, what they generally do is update the respective workplace, the sector-specific guidance, and then you go back and take a look at those guidances to make sure. The worst thing is having wrong information when you're, and again, when I'm talking to people, I usually have the most current document up because sometimes you don't even know what get changed. They don't tell you what they changed. They just put a new date on it and say revised. And so you can skim through it and see what changed. So.
How about explanations? We don't do, so I'm not looking for them tonight, but are there explanations on why? Just like one sentence generally. Do you expect to have one sentence explanations about the science? I'll use that term behind those changes. I'm not against the changes. Please understand.
No.
Just explaining.
I think, and they often preface it, and I was reading from the governor's press release, and again, what they're basing it on is improving public health metrics, and the ones that they look at to make those decisions, and the vaccination rates. I mean, they in the document they mention that Massachusetts remains among some of the first in the nation for vaccination. So again, that combination of vaccinating and public health metrics, I believe, are what they're using to make these changes.
Yeah, I'm talking about the little diagrams of maskings and aerosols and all that. Never mind. My suggestion is that when it officially appears, and if it is accompanied from any of the state agencies that have diagrams that look anything like the CDC's, or they get posted, I'd like to ask the two aces here, namely Louise Nichols, who really can bore down and make things very clear, and Katrina, who can, as it were, make sure what's clear is actually the real world. So I'm hoping those two aces, if they see something in there, because I'm out of the game now. I'm so confused. I'm going to go to Greece. Okay, they're open. Thanks, Jim. I appreciate it.
No problem.
I think you're right too, Mike, because they've opened, but they're also saying if you're, we're rolling back this way, but if you're vaccinated, you can do this. If you're not vaccinated, you can do that. Very confusing.
I know I feel like a teenager all over again. Yeah.
All right. Anybody else have any questions for Jim? All right. So we'll move forward, and hi, Katrina.
Hi.
Week off.
I took the week off.
Good for you.
I had a lovely visit with my vaccinated parents for the first time since July. So it was
Wow.
awesome. All right. So we'll dive in. First, Mike, I completely agree with you. The CDC's messaging was hard to follow. I'm going to take a stab at trying to simplify it tonight. You guys can tell me where we can improve for the future. So let's just run through the metrics first. So this is the 4 main metrics on the state's page as of today. And there's some really encouraging signs that Jim has already alluded to with the changes in the mask orders and things coming up. So let's go into some detail. This is maybe the one not encouraging sign. Maybe it is. We don't know yet. So the number of tests that were conducted over the last 10-day period really declined. And that could be a couple of reasons. It could be that we just have less COVID, so you don't need to run as many tests, but it was also April break. So this is, and this is the same pattern we saw over December break and February school breaks. So this is, for the last Mondays, every Monday for months, we had about 130 tests conducted. In the last 2 Mondays, we've had about 96,000 tests conducted, and they fell on the holiday, and they fell and this week. So there's a little bit of a lag happening in reporting. There's a little bit of catch up that has to happen after every break. So we need to wait a little bit longer to see if this is the new level of testing or if this is just the dip from the April break. So we'll see what happens over the next coming weeks. So like that, this is the test positivity. So the number of positive tests over the total number of tests conducted. The test positivity is about 1.7%. Compared to 2 weeks ago, it was 2.4%. So the last time I was sitting in front of you. So that is a little bit of a dip, which is great. We've been trending down in those last 2 weeks. Unfortunately, given the reduction in the number of tests, the test positivity by age group has become really unstable, and we can't really look at that at this point. So again, next week, we'll have a better idea about this test positivity. Similarly, number of cases have gone down. So we were already on a downward trend before we hit April break, and it's continued down. So hopefully, again, this isn't the number of tests issue, but we might still see a little bit of a bump up if tests and catch-up time is happening. But as you can see from the graph, the 7-day rate declined to about 1,200 cases, an average of 1,200 cases a day. The last few days has been a lot less, but again, we're coming off that holiday period, so we will see where we are then. And when you look at rates by age group, the age group with the highest rates over the last 2-week period is the 15 to 19-year-olds, followed by the 20-year-olds, and then you have that bell-shaped curve for all the other age groups. So what matters for this age group stuff isn't necessarily this last 2-week period, this little snapshot that we have. We want to know which way they're going week over week, so the trend lines. So here are the same rates, which I've been graphing over the last 6-week period. So the good news is that as of this week, all age groups have had a decline in the case rate over the last 2-week period. And that has been 2 weeks going now. So everyone's kind of dipped down. The most beautiful thing I see on this map is the 70 to 79 and the 80-plus-year-olds. And if you zoom out, you can see that this around 100 per 100,000 has been this way since the beginning of March. It's awesome. These early groups that we prioritize for vaccines, about 6 weeks after they started being prioritized, we had this steady rate for them. So regardless of the surge that was happening for everyone else around the beginning of April. So this is a great sign. And this is what we hope to get to for every group who will be eligible for vaccine. So this is what we're hoping for. So hopefully everyone continues down, especially as more people get vaccinated. So when I left you 2 weeks ago, hospitalizations were actually on the rise. And that was the one lagging indicator that it was like, something's happening. At this point, it's actually started to decline again. So the 7-day average for hospitalizations is 620. And the age of those hospitalizations was declining over time, as we expect with the vaccinations, who's been eligible for vaccinations. It's now about 61 years. And the hospital capacity is about the same as it's been over the last 2 weeks. So we're retaining our hospital capacity limits at 87% of hospital beds being occupied and 75% of ICU beds. So again, we're not having a strain on our medical supplies, basically. And then the best news I see on all of these is that the number of deaths continue to remain low and have been this way for about 2 weeks now. So at this point, we have 9 or 10 deaths a day reported, which is, when we look at last spring and when we look at all fall and over the winter surge, we haven't seen this since last summer. And this is awesome. So let's hope it stays here. The other beautiful thing on these metrics is the vaccinations. Our state is leading the way in terms of people opting into getting vaccinated. This is last Thursday's report. So April 22nd, there was 2.1 million residents fully vaccinated here in Massachusetts as of last week's report, which is about 1/3 of Massachusetts population. So it's still going to be about 1/3 when they do this week, my guess is. And as of last week, it was 51% of Middlesex County residents had received at least 1 dose. And the governor reported this week in his earlier press conference that 99% of people who get Moderna or Pfizer come back for their second dose. So I know that the CDC was reporting earlier, I think it was this week, that 8% of people were not returning for their second dose. And we don't have that issue here in Massachusetts. Part of that reason is because our vaccination program makes you schedule the second one when you're there for your first one. And there's a lot of reasons our program has really helped to retain people and get their second dose. So, and that was within the 40 some odd days, whatever the longest time frame is. So some people delay a few weeks, but most people are coming back and getting fully vaccinated and getting the benefit of that full vaccination and that boost with the second dose. So that's where we get the real durability in immunity for this. So then if we go into Littleton data, I'm going to present last week's data first. So last week we had 18 cases, and that was a decline over the prior 2-week period, a nice drop from the 32 cases we had the 2 weeks before that. And then when you looked at the areas that we've been tracking, everyone trended down slightly in terms of the rates. So the whole areas were trending down. And then test positivity, all areas were trending down as well. Littleton just had a little bit more of a drop in that 1 week period than the other areas. Now, if we look at the Maven sneak peek that Jim provides for this week, so this gives us the idea of where we're going for this week. So this 2-week period that we're talking about is last week, so April break and the week before that these cases are counted over. So we had 30 cases counted in that last 2-week period, which when you look 2 weeks ago is actually pretty similar to the 28 cases we had in April 14th. I always look 2 weeks back because these are 2 separate groups of people. And that means you can kind of smooth the trend line and see which way we're going. So we are essentially the same. We've held steady. We had this little blip in cases for a week, but we essentially are holding steady. It's where we were 2 weeks ago, 3 weeks ago even. And then when you looked at the numbers Jim shared for the entire area that Neshoba Associated Board of Health covers, the beautiful part of that is for the area, there was a really good reduction compared to 2 weeks ago and even compared to last week. So the numbers are going down in our area. Littleton is a slightly higher, held steady, and only one other town went up. So overall, our area seems to be trending down. We just might be holding on to our cases a little bit longer. So probably a few clusters occurred, and in a couple of weeks, they'll go away. So this is the health notifications for the schools, the letters that we get. I talked to Dr. Clenchy today, there were 3 cases reported over the break. So they're remote, they're not in school cases. And then so far this week, we've received 1 health notification letter about a case in the high school that came today. And as Jim mentioned in last week's meeting, DESE has a new close contact definition for the schools, and it varies depending on distance. So Dr. Clenchey did indicate that they're working with the Board of Health, Jim's crew here, to really make sure that we're capturing those cases. So it seemed like there must have been some found today, given today's letter said there was close cases. So I want to dig into the really pretty stuff for our town. This is the municipal level vaccination report as of last Thursday. So overall, we have, as Jim just reported, 56.5% with at least one dose of vaccine for among residents in our town, all residents in our town, which is amazing. And that was compared to 51% for the prior week. So we're making some progress over time. Of those 56.5%, 32% are fully vaccinated. So about a third of us are done with our vaccinations. And then if you look per age group, and these, remember that were prioritized based on the eligibility standards going forward. So they do differ. I've actually grouped them by kind of stage of life, if you will. So overall, Littleton has really good coverage for everyone. And then it also has good coverage among all the age groups. So the 20 to 29-year-olds, 56% of them have at least one dose. The 30 to 64-year-olds, I put those as like the family, parents, that kind of working age group. 70.1% had at least one dose. And among people 65 and older, 84% have had at least one dose. That's awesome. That remains like 280 individuals in our town in the 65 plus category who have not accessed vaccine yet for whatever reason. So this number has moved significantly over the last few weeks, and we hope it would keep going, but there might be pockets in there that are still having trouble accessing that. But given that there are more doses available at local CVSs or pharmacies and supermarkets and things like that, hopefully individuals will be able to access it at this point much more easily. And then, of course, when we get to this 0 to 19 group, that's not exactly a fair way to represent them because only 16 to 19 in that group are eligible for vaccination. So let's focus on the good part of this. Of that group, there have been 174 people, 16 to 19, that have received at least one dose. And that's 9.2% of the overall population in that 0 to 19 group. So that's, I have to say that looking at social media and talking to parents in town, it's been really encouraging and exciting to see high schoolers get their first or second doses over the last week or so. It's just felt really good. And I think that will do a lot to help protect our high school age population going forward, especially since they're at the highest rates right now. So anything we can do to help lower that is great. So I'm really proud of our 16 to 19-year-olds. And then for, of course, every person who gets vaccinated, we're going to end up protecting those who are unable to get vaccinated. So the less ability for the virus to move around, the more we protect everyone. So that will help the younger groups as well.
And they've all done it without a promise of a savings bond too, right?
I know. No one needed to be paid.
Good job.
10
Good
years
job.
from now. So the other little bit of difference, the state provides this information by sex and by race and ethnicity. Race and ethnicity is high across the board. It's wonderful. I'm not even going to present it today because it looks really great. There's the female residents in town are outpacing the male residents in town in terms of receiving vaccination, at least one dose. 61% of females have received at least one dose compared to 51% of males. This is actually something that's happening across the US. There's women just tend to be more on top of healthcare, help getting it for their kids. I scheduled my husband's appointment.
We're smarter.
We're smarter. I scheduled my husband's appointment, so maybe that helped him get into that vaccinated bucket. But so I do find this discrepancy a little interesting, and it would be interesting to see if we could help move it a little bit because while the rates of infection are similar for males and females in our state, males actually have higher hospitalization rates and rates of death as well. So if there's any way to help prevent sickness through helping people get vaccinated, if anyone has ideas, there's ways to reach groups just to help move this one a little bit. But overall, we're still high. That's still 51% of men in our town. So hopefully that will keep moving over the next few weeks. Doesn't hurt to have some competition though. So if men want to outpace us, let's do it. So the CDC updated their data on SARS-CoV-2 variant lineages. I think it was today or yesterday. And so this is the new bar of the most recent 2-week period. So you can see that B117, which is the UK variant, the one we know originated in the UK, continues to grow. It's now around 60% of the circulating lineages in the US. This is also the most common one here in Massachusetts. So that's the one that's much more transmissible, has some data that it may be more severe. This is the one that's really like hitting Michigan really hard. And then Massachusetts also has the P1 variant, which is the one that originated in Brazil, which is actually about 77% of our circulating viruses, according to the most recent measure, which is actually double what it was 2 weeks ago. So that is concerning that one jumped so quickly. It's still a small proportion, but it doubled over the 2-week period. And then Mass also has the B1427, B1429 variants, which are the ones originated in California, which are around 3% of those that are being measured. So that's similar to the proportion they reported 2 weeks ago. So what does that mean for us? Like the bottom line is these variants are here. Many of them are more transmissible. Some of them have can confer more severe disease. So it's just, there's more reason to take care at this point where you can, or get vaccinated so that you really do have protection. All of these variants that are in Massachusetts are still matched well for our vaccines. So getting vaccinated is your best way to prevent spread and severe disease. So that goes to the cheese. I took away the cheese. And instead, we know what to do. We know what these layers are of things we need to do. So not only do we have more transmissible variants here in Massachusetts, but our web of connections continue to be wider than they've been ever since we closed down last spring. A lot of things are opening, and we're talking about opening more, which is great. If we can keep our rates where they are or lower and continue to open up things, that's where we want to go. So as we do this, as we walk through this weird period where things are changing and you're not ever quite sure what you need to do, it's really good just to keep remembering your family status and what you can do to prevent spread. So the same things that we've been talking about, indoors is much higher risk of transmission than outdoors. I've seen studies where it said that, let me move to the next slide here because it kind of fits in. So this comes into that CDC guidance that was just released about the masks. So the studies are indicating that you have a 20% lower risk of transmission outside than inside. And that's because when you're breathing outside, you get all the COVID particles dispersed really quickly, air is moving. It's just a bigger volume of space for those particles to disperse in, plus you have UV and other deterrents for it to spread. So that is part of the reason that the CDC came out and said that if you are outdoors and fully vaccinated, you get to do more things without a mask. Like that's the benefit of being vaccinated. So in addition, Mass came out with the mask order, which I agree with Jim. I don't know the specifics of where exactly those outdoor venues where you will be told you have to wear one, because that's the sector specific reopening guidelines, and where if you're walking down the street, taking a walk in your neighborhood and you feel okay not wearing a mask, then you don't have to. So that begins April 30th. So that individuals will be required. There will be, when I listened to the governor this week, he's very specific about events. You'll still have to wear a mask. Anything in a crowded setting, indoors or outdoors, you'll have to wear a mask, like at Fenway, like at the prom, at any local sporting events. If you're sitting on the sidelines, you might just want to wear a mask just because you're in a group setting. But and I think those sector specific things will label that out for us where we do need to wear a mask. But the general idea is outdoor places where you can maintain 6 feet of distance, you don't have to wear a mask. So that's those walks, that's the hikes in the woods, that's the you're taking a run or riding your bike, things like that. You can be a little more relaxed and not have to wear your mask. So Massachusetts didn't specify it for vaccinated or unvaccinated too. So just keep that in mind. But then when you try to compare these and every state's doing something different, it gets really confusing, to be honest. So when I was looking at messaging around this, I was trying to break it down as what is the easiest thing for me to remember, because I'm sitting in a family where I am now fully vaccinated, or have had my second dose, and in 2 weeks will be fully vaccinated, but my kids aren't. So how do I handle this? And the general concept that this made the most sense to me. So the CDC, you have the CDC guidance and saying vaccinated, unvaccinated, and differentiating. You have the state guidance just saying outdoor, you don't have to wear a mask, but indoors you do. And the easiest way for me to remember how to protect my family is really kind of thinking 2 out of 3. So the way to slow the spread is by doing 2 out of 3 of these things every time. So keeping your distance, wearing a mask, or be outdoors. So if you think about that, if you are outdoors and distanced, you don't need a mask. If you are outdoors, but you can't keep your distance, wear your mask. And then if you're inside, you need to try to be distanced and wear a mask when you're among other people outside of your household, unless the sector-specific guidelines tell you can do otherwise, like school. So just trying to keep to it. This was easier to me. This was simpler. You guys can give me feedback whether this is the way this helps or it doesn't help. And then as more and more people get vaccinated, the rates should go down. We'll be able to pull back on masks. We'll be able to do more things. Things will open. And if then the metrics stay low, we can do more and we can do more. So the benefit of people getting vaccinated is not only protecting themselves against severe disease, is that we're preventing spread. And if we prevent spread, then we get back to normal quicker. So the more and more people we can get vaccinated right now, the better. And then until then, do more things outside. Wear your mask where you can't keep distance. Just keep doing the layers of cheese that we know work. Right. And then let's just end right on the, I think I'm ending on this, on the most critical thing we can do is get vaccinated. I've just said it multiple times here. So at this point, I'm getting notifications hourly about where there are appointments available for vaccines. I went to go get my second shot today, and I passed 2 clinics that were offering walk-in, no appointment needed vaccination sites as I drove by. So I don't think supply is going to be our issue if it much longer. I don't think it is right now. I think at this point, people just making an appointment and going when they can is getting people to do it is the next step. So there are plenty of appointments coming. They're definitely closer to home than they have been in the past. So hopefully people can get those appointments and get vaccinated over the next few weeks. And getting vaccinated is the most effective layer of cheese that we have. It's how we get back to normal. So the more people who get vaccinated, the quicker we get there. The quicker we get to start taking our masks off some more places and doing more social things, more businesses open more for business, things like that. So if you haven't made your appointment yet, I really encourage you to start trying. And if you need help, there's the Mom's Facebook group on Facebook is on top of helping people get appointments. And if anyone else needs hints, we could probably figure out how to help people. And then there are a lot of concerns coming up. I'm seeing a lot of questions, concerns, some misinformation about vaccines being spread around. And very reasonable people are asking questions and about the safety and efficacy of these vaccines and just looking for information. So the best person you could ask for help right now is your doctor. Calling your doctor to ask, because they have your personal health information, your history of health conditions, and they can help you walk through weighing the risk-benefit analysis of whether you should get vaccinated or not and which vaccine is right for you. So that is, I would encourage everyone to reach out to their doctor if they have questions right now about the vaccines. But this is the thing we need to do. So hopefully everyone's getting there and we can continue to see those numbers rise across the board here in Littleton and beyond. This is it.
Great. Yeah, I saw by appointment only at Pheasant Lane, and then I got an email. I think I saw it on Facebook, Jim, from your group saying that Littleton CVS is now, it's hard to get an appointment, but Littleton CVS is offering vaccines now too. So nice and local for those men from town that need to get it. You know how they had teacher days, special teacher days?
We
Maybe,
can have Mondays.
yeah.
Tim, get on that.
Not
you-
you, Mike. We know you're already vaccinated. And can you guys, any news? I mean, the J&J pause, I noticed on your graph, there was no, it was all
Yeah, so that is the data as of last Thursday. So J&J had been paused through Friday.
Mhm.
So the last 2-week period, there was no J&J. So J&J, I didn't put anything in the slides. I should have done that. So the FDA, CDC, and an independent safety review board looked at it, and there was a long discussion about how to handle it. So the ended up being 15 events of this rare bleed event with thrombocytopenia. But it wasn't a point where they worried about it. They've improved the warning on the J&J vaccine, but they have they've said there are risks to COVID that also outweigh making it not available to that age group. So there were worries about people accessing vaccines if it would differentially mean they couldn't access. Women in that age group couldn't get vaccinated. There were still major risks for their health for COVID infection, so they didn't want to take that away as an option. But there are warnings now about that it's there and what to look for if you do get the J&J vaccine. But it's rare. Like at 15 out of, I think it was like almost 8 million doses given, it's a rare thing. So definitely look out for, I think it's like extreme, like really bad headaches, leg pain, trouble breathing, things like that happen a few days after vaccination to like 2 weeks after vaccination, basically. And then if you do go to the hospital to get checked out, just tell them if you've got the J&J vaccine. But if you are a woman in this age group that is affected and if you're not sure about it, you have options. There's Moderna and there's Pfizer. And neither of those, they actually looked for this signal in those vaccines and it didn't show up into those vaccines. So if I myself, being a woman in this age group of interest that we're talking about for the J&J and these bleeds, I might, if J&J was my only option, I would take J&J and I would look for symptoms in the next few weeks and know that it's a very rare thing. But if I have options and I can get Pfizer or Moderna, I would choose a Pfizer or Moderna option personally. That's my choice. But again, talk to your doctor if you have questions. They would help you figure out which is the best for you and your life and your access and health, all those things. So that's a great conversation to have with a doctor or your pharmacist or anyone.
Great. Anybody have questions for Katrina or comments? Go ahead, Louise.
Katrina, do you know, or maybe Mike knows, after you've had COVID, how long do you have to wait before you can get vaccinated? Or Jim, anybody who
Jim
knows?
might know.
Sorry.
You don't know. So I don't have it off the top of my head. I can definitely look at, there are guidances on the CDC website for each of the vaccines for that. I don't have it on the top of my head.
Okay. 90 days.
This is Mike. I don't know a great deal. In most cases, my suggestion from what I've read is you ought to consult with your physician who can arrange for any number of tests that would suggest what your current load is, what your serology looks like. That's your immune system profile. And it varies a lot from person to person, as you must know. So my only suggestion is that for anyone who is recovering or has COVID and wants to get vaccinated is to make sure you have an appointment with your doc and, make sure what the purpose is. When can I get vaccinated? What's the earliest? What's the latest? All the rest.
Okay, thank you.
It's not a risk. It's just the best time to do it.
Yeah.
That's a great question for your doctor.
Thanks.
Anybody else have questions, comments for Katrina?
I just have one for Katrina. And by the way, I was very serious about you teaming up with with Louise, just in case, because I looked at your diagram and I almost got it. Except for the vaccinated, the only time you were supposed to wear a mask is, and there it was. All right.
Indoors.
This is way, way too early, but I want to just ask the question and maybe it'll be forgotten and we can revive it at some future point. But at what point, this is early, at what point are we looking at what I call the slow burn phase state, somewhat equivalent to the flu during its season?
When we get to a seasonal pattern that this keeps coming up.
Or whatever the pattern is. In other words, is it a number-driven thing? That is, are there always going to be n number of cases of COVID, and therefore mask wearing will be X? I'm not looking for answers. It's just more of getting ready for, the Board of Health should be ready at least to start looking at, signs coming up. That's all I'm raising the question.
Yeah, I've started, the people I've been learning from, infectious disease people who I've been learning from, I think we're going to have COVID with us. It's going to be similar to the flu where it mutates. It's going to keep being there. We're going to need boosters, things like that. At this point in time, we don't need boosters. They're looking at them, so they're prepared for when the time comes. But a lot of that is, if you think about it, like we had deaths with flu, we accepted a certain level of risk with flu that we will end up accepting with COVID. I just don't know where that number is, if you will. So it will be interesting to see how that unfolds with CDC guidelines, the state DPH guidelines, things like that. That's still being negotiated. Basically, people are trying to figure that out right now. And a time when there's still surges happening in the U.S. There's still people at risk.
Yeah, I was.
Like that, so.
Yeah, I was looking at the long haulers. They seem different than the. Again, there's not a time to go into it. They seem very different, at least to me, than the folks who have difficulty getting past influenza flu.
Yes, definitely. There are definitely people even with mild disease who've had trouble recovering for a long time, months even. So I do think there's still plenty of reason to keep using the layers of cheese right now and not just give up now.
Oh, no, not now.
We want to drive down these numbers. Right now, we're still at a level that's just where we were in beginning of November here in Massachusetts. And we're doing well compared to other areas of the US. So if we can keep driving this down through vaccination, especially because that's durable and it will help prevent transmission, then we're going to be in a much better state going forward. It will be very interesting to see how things unfold, especially given that there are age groups who are not eligible for vaccine yet. So I anticipate that those mask requirements they're already in place for summer camp. But there will be a version of that going forward into the fall with school and whatnot, just because you'll have a high concentration of individuals who are not vaccinated unless their numbers are extremely low. And then that changes everything. And that's just not here. It's everywhere. So and we're lucky we live in New England where vaccines are being highly accepted and sought after. But it'll be interesting to see how this unfolds over the next 6 months.
The other thing that is very encouraging to me, at least, is the number of instances of proven transmission of the virus from vaccinated people is very hard to find.
It's very low.
Apparently the vaccines are very effective. However, it's achieved, and who cares, as it were. You end up not being a transmitter. So that's
So there are people who get sick after vaccine, like that. Yes. We expect that. We expect that for every vaccine. There will be a proportion of people who get sick following vaccination. The things I'm seeing is that they're still less likely to go to the hospital, have severe outcomes, death. And then even locally, some people have been partially vaccinated and gotten sick and been I lost my taste and smell. I had a fever, the few things that are but wait, it could have been worse if I didn't have one dose on board. So even then they realize, oh, had I gotten this before, it might have felt even worse. So I do think I'm very thankful right now that I have 2 doses, and in 2 weeks my immune system will kick in, and that will help protect my kids who can't get vaccinated right now too, just so we won't be bringing it to them. But it would be, the more and more people who get vaccinated, the more we I saw a great video. I just couldn't embed it into my thing, from the Museum of Science, talking about herd immunity with dominoes. And it was a really great way to demonstrate how herd immunity with vaccination really works and stops everyone falling down, basically. It spreading is how they were depicted it. It's a really great demonstration if people want to look up their website.
Great. Thanks, Katrina. All right. Kevin, did you have anything that you wanted to add or ask? Jim? All set? All right. Thanks very much, Katrina. Do you think it makes sense? Do you still want to do this once a week? Or is it making sense to do it every other week? And I know this is another topic that we can discuss later, but.
I take your lead. I don't know how you guys feel.
All right. We'll talk about it later in our comments. All right. I know Kevin Davis is here to talk about the notification app, or whatever it's called. I'm sorry. Janet, can you let Kevin in?
He's coming. It just takes a while. Sorry.
I know, we just made a quick little turn, so.
Hi there, everybody.
Hi, Kevin. Haven't seen you in a little while.
Yes. I'm sorry I don't have a formal presentation to give to you. However, I can report on what is publicly available right now for the state of Massachusetts as it goes to what's called Exposure Notification Express. This is where the technology has been integrated into people's smartphones. What this allows the Bluetooth technology to do, as a review, is to help aid contact tracing, that, if there's somebody does get an exposure and they choose to report this on the Exposure Notification Express app, that'll help let other people know. So when Jim Gareffi has to ask the 1,000 questions and where were you, where was this, where was that, some of that information will be gathered already and entered into the system via this automated tool. So that'll help out. But as far as the state goes right now, they're in a beta period right now with the software. So they're ramping it up to basically try to wring out all the issues. A couple of locations within the state, a couple of cities, I think, closer into Boston, have volunteered to help with the beta rollout of it and to try to sign up some of the residents to kind of go off. And that was reported in the news. If you go on the website itself, the Mass Gov COVID-19 notify site, it actually talks about what the app does. It talks about the privacy policy. It talks about how it does not track you. Again, I can't stress this enough. It is an opt-in thing. Part of the process by which the technology is turned on, it does not track location at all, period, end of statement. What it does is, part of the technology is that, think of it as, if you remember the faces in theater, you have the happy face and the sad face in theater. So what's happening is the Bluetooth, for one instance, is the happy face. So it's emoting that here I am, this is Bluetooth, this is a Bluetooth signal. And when it switches to the sad face in theater, it is actually collecting all those things. So it's switching back and forth very quickly between sending out a key and receiving keys from around you. So that's a technical description of it. Those keys that are being sent out are changed frequently. so that you can't actually track what's happening between people. So there's a lot of goodness that's gone into the system. So as far as the state goes, it's still in a beta phase. It's not quite turned. If you notice, you can actually go in and turn it on. If you go into your phone in Apple, you go follow the instructions. You basically go into the settings app. You scroll down, you'll see something that says exposure notifications, and you can go turn it on as an individual. If you have an Android device, you can go download an app from the Google Play Store for Massachusetts and turn it on. The state has integrated with the national database. So this is really awesome news, because that means if you travel somewhere and the exposure notification is available to where you're traveling, you can turn it on and it'll still get reported back appropriately when it happens. So this is really, really good news. Currently, I just recently looked at it. There are about 50% of the I think it's 50% right now. Yeah. 50% of the United States is using this technology. So that's really good news. So other than that, I really don't have much of anything else to report on, because the state hasn't moved to do a general announcement that it's on for everyone. But I just, that is the data that is currently available.
What do we actually do with this information when we get notified that we have come in contact with somebody?
So you'll get a little pop-up notification like you do for any one of your other notification apps. So you'll be a little thing that'll pop up on your window that says, please, go open this, and it goes and opens it and said, based on some data, you may have been exposed. Please call this number. That's all it says. It doesn't go into anything else. It doesn't talk about where the exposure was or anything like that. It just says, this is here. Please go call this number for further assistance. And then you go call the number, and a lovely contact tracing person will start walking through the data with you, start trying to figure out where you were, when it happened, and all that kind of good stuff.
Okay. Does anybody have any questions for Kevin?
I do, but I want to make sure everybody else, because I want to go in a slightly different direction, of course.
Go ahead, Mike.
I actually was hoping that the ones here in Littleton would go directly to Jim.
Thanks, Mike.
No matter where he is or what he's doing.
Yeah, with cell, right? Yeah.
But
It'll start sending out SMS notifications to text him each time something happens.
that's the idea. Jim says,
no, there's actually a group of contact tracers that have been specifically trained by the state to go and do this type of work. So it's okay, yep, you're notified. Okay, let's start digging into this and let's start doing that. So it's a good thing.
Yep. Oh no, there's no question it is. Yeah.
And one other thing, Mike, if you go up, when we're looking in Maven at specific reports, they collect lots and lots of information, demographic information, your lab reports. There is a new line in there now to collect. It's this notification express. So they're getting prepared to capture information.
So
the app is actually called Mass Notify. So that's the name of the app for if you're interested in the Google Play, to go out to that and go pull it down.
Kevin, what do you think it'll take to get it out of beta?
I don't know what the public plans are for that. That's something that DPH is definitely working with the state to try to figure out when to go and get it out. I don't see a reason from a technology perspective to limit this. I think it is definitely some policy decisions that are definitely trying to be made to try to figure out how to do this. I can see as we're opening up more, it goes to what Katrina was talking about. I can see this as a tool to be used, because as you're walking about, if you have this, how many of us carry around our cell phones? I mean, it's just there doing, that type of thing. I also see it really helping out schools, especially the mobile aware teens in middle schools and high schools, being able to, at least have that with them. It's just another tool to for us to use to help out for, Jim et al.
So there are like 30 something states that already have this thing like up and working and cooking, and
Yep.
why has it
I
taken?
don't know why. I don't know why.
My next comment was not a moment too soon, right?
Yeah, right. About a year late.
Yeah.
But thanks.
You're welcome.
This would be interesting, like you said, to see if we can get some younger people to sign up for it. So maybe talk to school committee or something like that. See if we can urge that.
It's certainly as soon as it becomes more widely available, it would be one of those educational moments that we can definitely push forward.
Okay, great. All right.
Can I ask my off-track question?
Of course.
It's really off track. Okay. Well, I was wondering, and no answer is required tonight, but from the very beginning, I've been thinking about the utility of this locally, not to do the tracing or to do the proximity, but to very quickly communicate with all the cell phone owners, everybody in town who has a cell phone, to basically be able to broadcast very quickly and anonymously, that is not identifying the recipient, but be able to spread an announcement or emergency announcement that's a public health announcement. Basically, it says X and Y is going on. Here's what you should do, full stop.
Like Amber Alert.
They have the
That
reverse
kind of,
911.
yeah, applying that
Yeah.
principle. Yeah, but
Yeah, the state already has that contracted out through a service. You actually get announcements through the state to go out and do that. Sometimes I've received 5 or 6 of them, and they're just from this. It's called it's like a 5-digit number, and I forget what it's a shortened number or something like that.
Yeah.
But there's a specific. You actually sign up for that, and you can trace back who sent it out and all that kind of fun stuff. But the state has already contracted out with a group to go off and do that. I don't know if it can go to a local area. I'm sure there is a way that you could reach out to the DPH to try to figure out to see if the local boards of health could play with that. The police department already has a notification system that is like code red or something like that. I forget the name of it. Say again?
The reverse 911?
No, it's not a reverse 911. There's an electronic app that sends stuff out. However, from a federal level, the emergency broadcast or whatever that's there is a federal response that can be triggered, and there's a whole list of things that goes into what happens with that. But that's all at the federal level. I think the governor can plug into that, but I think that's as far as it kind of goes down from that sort of kind of thing. I am not aware of a local interface into any of those systems. But that's something definitely to reach out to the DPH to see if there's anything locally that can be done for that technology.
Yeah, this is entirely simulated by the frustration that if you watch any of the quote cable news sources, or sometimes not even on, basically they pump ads out that are very local. So if they can punt, change your windows ads, I think we could get health information, especially emergency information out locally. Thanks, like, I don't want to take up our time with this.
No,
looks like there's sources. Thanks.
You're welcome.
All right.
Can I return for one moment to my vaccine talk? I forgot 2 things that there's been some recent information going out there about the vaccinated people impacting unvaccinated people's health, like by proximity. And this like exploded this last week, and there are people even locally who have concerns about this. And I just think it's really important for people to understand that the vaccines aren't live virus; they're not contagious. So the way that they basically deliver the instructions for your body to make the spike protein antibodies that it needs, and then you get absorbed and flushed out of your body. And it can't be like just because you're in proximity to the person who has been vaccinated and you're not, it shouldn't impact your body if you're unvaccinated. So I think that is a very concerning rumor that is impacting a very certain specific demographic, specifically women of childbearing age. And it's something to just keep our ears to and try to refute wherever we can and provide information for these people to help make them make informed consent decisions about getting vaccinated. I've tried to do that on Facebook this week. And the other thing that I don't think people are aware of, and it's really important, is that the CDC and FDA have a vaccine adverse event reporting system. It's called VAERS. And everyone who has been vaccinated and you have anything that happens in your health that you have a concern that seems related to the vaccine, you can report it through the website on the CDC website. And I actually signed up to do the VSafe app, which is from the CDC, where they actually send me prompts to ask me how I'm feeling after my shots and to collect information actively about any adverse events. So I have been doing that. And again, that's on the CDC's website. When you look up VSafe, it will come up. I can put them in my presentation the next couple of weeks, but so if you have any concerns that are coming up, that's a great way to report it so that then they have the information and they can look for adverse events and start really continuing to develop the safety profile of these vaccines over time.
Great. You feeling okay today, Katrina?
I am sitting in front of you and I would like to go to sleep right now, but that's normal for me with any vaccine. So my arm is sore as well, but I'm feeling pretty good actually. I drank a lot of water, so hopefully that will help.
Good. All right. Does anybody ever have any questions for Kevin or Katrina? You can let her go to bed. All right. Great. Thanks so much for the updates. Hope you feel good tomorrow. So we're going to move on to correspondence. And I think we all received the letter from Mr. Kane. And I think Mike wanted to make some comments. Yes, go ahead. Are you ready, Mike?
Sure, unless some other members of the board want to comment. I mean,
well, you reached out and said you wanted to comment, so
only because I'm the one who lit the fire. So okay, here we go.
Yep.
First of all, I'd like to thank Mr. Kane for a very thoughtful, well laid out, logical letter, and he succeeds in raising some very important questions. One of them that I think deserves an answer is that he felt with some very good reasons why we should start with a director of Board of Health. A director of Board of Health, if we were going to do this at all. And what he may not appreciate is the fact that it has been considered in putting together the plan. However, at this time, it's I think one of the key pieces of information that may not be very obvious. We try to get it across, but the main thing here to keep in mind is that the Board of Health here in Littleton, that's the elected board, actually has by law the responsibility for establishing policy and direction for whoever carries out the requirements of the Board of Health. So the tasking, just want to repeat that. In other words, it is the Board of Health, that is the elected board, who is responsible for establishing the policies and the direction. And a director would definitely be in the same realm. This has to be viewed in the following context, that we are in fact an extension of, that is the Board of Health in Littleton and other, I think there's 235 boards of health, just to give you an idea, in Massachusetts. And under home rule, we are an extension of the state's Department of Public Health. So in effect, it's the state's Board of Health who provides other boards of health, that's us, with a lot of direction, with basically the major themes of policy, mandates, and all the rest that flow ultimately, of course, from the governor. So having a director would put us in a position of having to have some very specific need a very specific programs and direction that is somewhat unique, shall we say, and extremely important for, shall we say, our particular location in town. And at the moment, we're simply not large enough. You'd be surprised how few towns have directors of Board of Health. It's a title. doesn't reflect the experience. It's not uniform across the board. So those are the reasons why we didn't go initially, or have not thought initially of going in this direction. Plus, we're very used to a high level of competence, thanks to Jim. So we already have a high standard, and we don't intend to go below that. So it doesn't matter what the position name is. They have to be at least be able to stand in the same room with Jim. So we have to make that very clear. The other thing is the organizational structure. I believe that Mr. Kane was very concerned, as I think some of us are, and maybe continue to be, about the placement of what appeared to him to be the placement of the Board of Health somehow within a department called land use. And I think what didn't come across, and I guess I'm the one at fault here, is to make it clear that that particular position, that particular designation is an administrative one. We are still legally, that is, the Board of Health still is the only entity in town that is responsible for public health. We are it, as it were. This doesn't absolve the select board or anyone else from, quote, responsibility for following through or assisting and all the rest. I'm simply saying that the Board of Health is it, and regardless of where our assistance come from, our support comes from, we're the only ones, along with whoever is following our direction and policy. That's by law. So it doesn't make any difference where that individual is sitting. It matters where his policy and direction come from. So I think that's fine. And as far as the oversight, I'll just repeat, it's the elected Board of Health that provides that oversight, obviously in consultation with the professional. So, because you just don't go off and give oversight, because we are looking at areas of expertise and professional competence. And one of the reasons you make an appointment in this area for whether you want to call it a sanitarian or a health officer, whatever designation is given, you want to make sure that there's a certain high level of competence and professionalism that's a prerequisite for the position. So I want to thank Mr. Kane very much, and hope he continues to keep an eye on what's going on and what's happening. And I'm very interested in having an input that's both clear and based on realities on the ground.
Great, thanks, Mike. Did anybody else get any more correspondence other than that this week?
I just wanted to comment on Mr. Kane's input. I feel like, Mike, you did a fantastic job at the Board of Selectmen meeting, select person meeting. I was going
to talk about that in comments.
I feel like after reading Mr. Kane's letter, it would make sense to hire a sanitarian first, with the idea of, shall we say, grooming them to be a director of public health, or having them have the background or expertise to perhaps be molded into that position. I just think we need to keep an open mind about that. I know that the day-to-day of a sanitarian and everything we have going on in town, we need that person. But if they were to be able to grow into it, that might be a really effective way to proceed. In regards to being a part of a land use department, I feel like we might be not shooting ourselves in the foot, but not giving ourselves the best chance to be successful as a Department of Public Health by including them in a land use department. I feel like they should be Department of Public Health. Doesn't have to do with land use, health.
I just like to repeat I hear you loud and clear. The notion here is it's going to be the place where, if it goes forward, it will be the place where requests are made for service, a record is kept.
Mm-hmm.
It still can only go to one person or one organization, which is the Board of Health.
Right.
Okay. Where the Board of Health agent is going to sit, I have no idea. It may not even matter because legally and from a point of view of executive ability, nothing will change. Okay, whoever it is that is chosen to be the health officer, whatever the title is, legally, no one other than the Board of Health elected by the town can basically provide that direction.
Understood.
That's and
I just
the
feel
rest
like
of it, I
with
think.
town politics and people,
I'm sorry, what?
I just feel like with town politics and people being under the same roof in the same office, like let's just have a Department of Public Health.
Well, I'm sure we could have a long discussion about this, but I just want to also, maybe Jim, I hate to ask you this, Jim, but I've seen health officers, sanitarians, and directors of Board of Health listed as land use in many towns around Massachusetts. This is not unusual. At least
So there is,
I'm sorry, Jim.
yeah, there is I was assuming that was a question, Mike.
I thought you would probably know 10 times more about this than I would. I only saw 5 towns. I ran out of interest after 5.
So it seems they end up in either kind of a land use or Office of Health and Human Services Department. I see just as many ending up that way there too. To the point of a land use, there is a health component to the land use operations, and so it makes it very useful to have the Board of Health in that office, because even if you're not working directly on something, you're generally listening, you're hearing. The planner has a question, you are there. The building commissioner has a question, you are there. Conservation has a question, you are there. It makes for a very coordinated service for the townsfolk to have all of those, because the Board of Health does have particularly in a town with wells and septics, does have a component that's land use.
See, he knows 100 times more.
I just live it, that's all.
All right. Any, all set with this correspondence, everybody? All right, and I'll start off with member comments and.
Oh, I had one more piece of correspondence. I'm sorry.
Okay. Yeah.
Did you all have a chance to read the letter from the DEP regarding the point today?
I didn't receive anything.
Really? It was CC to the Littleton Board of Health.
Who sent it to you?
I saw it online. I didn't actually get it from any
What was the date on that letter?
today. It was this morning.
Did it say it approved provisionally of the conceptual plan, something to that effect?
No, it was something regarding non-compliance and $25,000 a day fine.
Yeah.
I did not receive anything today.
Huh. I'll see if I can dig it up.
I think if anybody would know about it, it would be maybe Jim would, because he generally knows more than I do
It was
all the time.
on the bottom. It said CC Littleton Board of Health.
I'll have to take a look and say, you said it was, you saw it today or it was mailed today or?
I saw it today electronically.
Okay. I'll take a look.
What, Jim, this is a place where your wisdom plunges in. You may not, as far as I know, that system over there is so large, or that is so large that it falls almost directly, if I'm not mistaken, under the state's operation. I think it's environmental protection and the Board of Health. Is that right, Jim?
So it's a wastewater treatment plant because of the number of gallons per day. And it is the DEP's jurisdiction to handle systems over 10,000 gallons a day, which that clearly is. And so often when they are issuing permits, issuing letters, issuing information, they will copy the Board of Health just to let you know what they are doing in your town. So that would probably been for your information. So let me take a look and see if there's information.
The point is, it's out of that means, I think, although I don't want to take any power away from stop Jim from going over the point and give them, some instructions, but
No, there's nothing
that he's,
Oh, no, this is the DEP. I mean, that's
Yeah.
just their bailiwick. So, yeah.
yeah.
but I feel like it might be a really good topic of conversation for this board of health to maybe bring back the regulation regarding wastewater treatment plants in Littleton and any systems over 10,000. Is it 10,000 gallons a day?
Over 10. Right now, your jurisdiction is up to 10,000 gallons.
Up to 10,000. It might not be a bad idea for us to take a look at least being able to have a conversation about and regulate these larger systems that could potentially be affecting our drinking water, especially amid this water crisis we have right now. I forget what the regulation number is on the local regs. Jim, I don't know if you recall.
I do not.
Yeah, it was probably, I know Ted and Mr. Yap had some say in that in 2011. We might want to take a look about discussing that and seeing if we want to have some say in that moving forward. Lisa, I don't know what your take is on it. Muted.
She's muted.
Sorry.
Lisa, you're muted. Yeah.
My dogs are coughing. Maybe we want to get a little bit more information and get well informed before we start discussing it. So we can ask around.
Yeah, I'll see if I can forward that information from the DEP over, and
okay. Maybe we can get explanation from either Jim or DEP. Yeah, that'd be great. Okay. We're going to move on to member comments, and I just comment. Mike, thank you so much. Did a great job explaining everything on Monday to the select board, and I think they're moving ahead. So I guess that's all. Just thank you. Did a great job. Appreciate it. And I've told the rest of the board to watch.
you look good in that jacket too, Mike, I have to say.
Yeah, very dapper.
Yeah, very dapper.
He didn't wear one tonight, though.
I must explain. I only wear that to sporting events. So when I go to Fenway Park or go to what used to be North Station or whatever it's called, I'll wear it there. Only sporting events.
Does it bring our team good luck? Is that why you wear it?
I have no idea about its effect on betting. It has lots of pockets in it.
Your mask and your hand sanitizer, your other mask.
Pocket. Yeah.
No, they're just things that you take along to a baseball or a football game. That's all I got to say.
All right. Any other member comments?
No.
Mike, Kevin, anybody know where Gino is tonight? No.
Arizona?
Arizona?
I don't know.
Oh. He didn't say anything. All right. We'll go on to, actually, I had a question too, and I think Amy Tez is in the attendees. And Kevin, you had talked a little bit about doing something regarding mental health. Any heads up on that?
I think Amy might have some comments.
Okay. If we're done with member comments, we'll go to public comments. Amy, you have your hand up.
Hi, it's Amy Tez, 117 Whitcomb Ave. I was able to pull a little data together for you guys. I don't know if now is a time to share that, and some information about public health measures that are kind of recommended or to be considered for communities in supporting resident mental health needs.
Is this something that we should add to an agenda, or is it some comments that Amy can, maybe some brief comments that you can make, Amy? To segue.
Yeah, I mean,
to segue into an agenda topic.
Yeah, I can certainly, if it would be more helpful, I could send you maybe a write-up of some of this stuff, so you have it ahead of time
Yeah, that would be good.
to read through, and then we can talk about it at a meeting.
Yeah,
If that would be helpful.
Sure. But did you have any comments tonight? Did you?
Yeah, I mean, I think I think, you know, the data is lagging a bit just because mental health data is usually reported, you know, last year's data gets reported this year, but there are some recent publications with data sets that really do point to the need for communities to pay attention and help build resilience for people, because mental health issues are on the rise and supports are really limited out there for specialist care. So I'm certainly happy to send you more specific details. I can send you guys a write-up, and then maybe we can talk a little bit more. And I can share some of the recommendations that are out there for consideration. And maybe that's a place to kind of start the conversation in a meeting next time.
Okay. And with the more of a public health concentration to it too?
Yeah.
Okay.
Yes, definitely.
Yeah, that'd be good.
Great.
So go ahead, Kevin.
Amy, what's the number one problem facing public health, mental health these days out there as a professional? If you could give me some insight.
Well, I think the struggle is that there's not a ton of real fleshed out data right now, but what it looks like is that anxiety and depression are significantly increased. You know, anywhere, you know, from I would say around the 40% mark is what it's looking like from even August of last year. It's up. So I think with that, you know, on the ground level, it just means that people are struggling. There's not, there was already kind of a shortage of specialist care, psychiatry, mental health supports on the outpatient basis. And I think as providers get booked up and the longer the wait lists get, the more we're likely to really need preventative and other community-based supports in place to just help build resilience for people. So not necessarily diagnosing and treating, but creating buffers so that we can maybe, you know, stem some of that, some of the increase for more intensive support like ER or inpatient, which is also on the rise. You know, I think there's a lot of data now. I don't really want to talk necessarily about suicide rates because I think they're not, there's a lot out there that's kind of misinformation about that right now, but for sure in Massachusetts, the ER rates for youth for mental health are on the rise. They've really been significantly decreased for physical injury, which you would expect because kids aren't doing as much, but the mental health side, things are really going up. So, but it's across the lifespan. I mean, I think, you know, 60 to 69-year-olds are another age group of concern that need to be paid attention to.
Just by being alone?
Yeah, there's some data out there about, I think, you know, when it comes to pandemic related stress, you know, job loss, financial insecurity, loneliness, you know, just, you know, there's, you know, the racial disparities, you know, socioeconomic stuff. And I think we're not seeing a ton of answers necessarily yet about why exactly these age groups are there. There's a lot of guessing, but I think they are being, you know, there are age groups that we need to pay attention to, that there's a lot of research right now that's saying that we need to kind of make sure we're protecting more. So 18 to 29-year-olds, 30 to 39-year-olds, and 60 to 69-year-olds were in the CDC reporting were amongst the higher risk groups right now.
It's a lot of people.
It's a lot of people. There's a lot. The numbers are not pretty. I'm not going to lie.
Just a quick question, may I, Madam Chairman?
Yes. Yeah.
Are there any countries in the world in which the indices that are used to measure depression and anxiety, are there any countries in the world in which those numbers are markedly better than ours?
I do not know that for sure. I can certainly look. There's some, we don't use the same measures necessarily. So a lot of the measures that are used here are normalized on Americans, not necessarily other countries. So it's, you know,
So you're saying the
saw some
DSM, I'm sorry, you're saying the DSM is not adopted in enough countries to use it. Is that what you mean?
No, I'm saying that the rating scales that are used, not DSM, but the rating scales that maybe physicians, like your primary care physician, would give you, something like the something called the PHQ-9, which is a patient health questionnaire. That's something that's you know, when they do some normative work on trying to get data for those things, they're not necessarily used worldwide. And I can look at the WHO to see what they have. They often share a more global perspective about mental health and things, but I think that data is probably going to be lagging as well.
Good, my dog is coughing. If you could get that information and
Sure.
and we can talk about it. I don't know if we put that in the COVID update meetings every other week. Would that give you enough time to? I don't know, Janet. What is this? Is this public hearing week? I guess we've had one. That might give you a little extra time if we meet in 2 weeks, Amy.
Okay, yeah, that sounds good.
I'm sorry, Janet. What were you going to say?
I was going to say this is a public hearing week.
Okay. So next week either next week or the week after, or 2 weeks from now. Is that a good time for Amy to get in? Or 3 weeks from now?
2 weeks from now is fine.
Okay, that might give you a little bit more time, Amy.
Yeah, great.
Okay. Good. Look forward to hearing from it.
Good question.
Thanks.
I wasn't at the school committee meeting last Thursday. What did they decide about mental health and how they're going to approach things?
I was there.
I did attend. They talked a bit about the intervention. You know, it was just a presentation of the interventions that they have that they're implementing right now. I don't know that we got real numbers around what they're seeing as far as how many kids they're interfacing with now, or how many families they're interfacing with right now, and the supports that they need there. But they did put a comprehensive list forward.
I was wondering if Jim, in his experience in the areas that he's covered, whether or not he sees any data or has some sense about what his organization sees.
Do not. What most of our towns, when I first started, belonged to, used to be called the Lipton Center, then Community Links, and then I think like Littleton Boxborough used to belong to Concord Family Services, and there was one other entity. And so those were taken care of by, you know, the people needing those services were taken care of by those entities. So don't really have a lot of experience with it, Mike.
Okay, it wasn't so much the clinical thing. It was basically what I call preventative or community based, basically to, as it were. I think Amy used the word stem the tide, as it were. I'm not sure I want to use that term. It sounds a little bit discouraging, but okay. Thanks.
Jim, what was the one that Littleton was a part of?
There were two that Concord Family Services, I think, was one of them, and there was one other entity too that you used to pay like I don't want to say an assessment, but a fee too, and residents had access to those entities. There were two of them, like I say, Concord Family, and then I forget what the other one was.
Yeah, but those are clinical. They're basically medical based, or what we'll call. They're not preventive. They
You
are.
have a diagnosis and you go there and you.
Well, you get the diagnosis there. Okay. The idea in community health, I think, is to first of all try to do something to, shall we say, whatever's going on in the community around you, to basically build the community up so it doesn't happen as frequently. It's not a question of I've got it now, how do I get rid of it? It's basically reducing the
Prevent.
opportunities to come to find yourself in that situation.
Now, I can tell you now that our town, the Elder and Human Services Department, refers out to the William James Interface Service, which is a referral. It's a free referral service for people who are seeking mental health care. So the service will help them locate somebody who may have availability and meets their needs and insurance and all of that stuff. So we do offer that in our town. So we are connected with them. And I think the things that I'm looking at sharing are more geared at, a referral service is important, but at how can we target the general public with information and maybe other kind of programming that offers a buffer that's not necessarily clinically based, but provides a level of support there that might ease and take the pressure off a little bit.
Yeah, I think that's what Mike was talking about last week for public health and individual, therapy with a doctor and a physician and a patient. So, all right, great.
Yep.
Anybody have anything else to add? All right. Any other public comments before?
Your hands are up?
No hands?
No hands.
All right. So you guys feel like we can adjourn?
Motion to adjourn.
All right. You need a second?
Second.
All right. So we'll do a roll call. Kevin Baker,
Kevin Baker, yes.
Louise Nichols,
Louise Nichols, yes.
Mike Zeldin,
Mike Selden, yes.
Lisa Flanagan, yes. All right. Thanks very much, everybody.
Thanks,
Right.
Jim.
Thank you.
Oh, I
Yes.
guess I forgot, next Wednesday, 7:00,
Same bat time.
the 5th, May 5th. Okay.
All right, good night.
All then.
Good night.
Thanks. Good